Hi, welcome to the Spine MDT. So what is a cervical foraminotomy, a posterior cervical foraminotomy? Well, this video is about the procedure itself. So if you've been offered the operation either by me or another surgeon, it's just some information about the procedure itself, its benefits, what the risks are, what it's treating, just so that you can make an informed decision. The purpose of the surgery is to treat cervical radiculopathy. There's a whole video on cervical radiculopathy on the Spine MDT blog page, which is essentially pain radiating down the arm, which can be associated with weakness or numbness in the arm, and that's a result of a trapped nerve here in the neck portion of the spine, the cervical spine. So here is a cross section across the neck. That's the front, this is the back, that's the right and left. This here is the disc at the front, which has protruded and it's pinching the nerve, and that sends pain down the arm. The video is also available on our YouTube channel, so click the link to have a look at the video on what cervical radiculopathy is and various ways of treating it. So let's dive straight into it. The idea of the operation is, if you have a trapped nerve in the cervical spine, is to try and untrap it to alleviate the pain. So once again, we have a look at this picture here of a normal spine. This is a cross section, so if we slice you across the neck and look up from your feet, this is the front, this is the back, right and left, and this is the arch of bone at the back of the spine. What it normally looks like is, here's a disc here at the front. This is the spinal canal, the sort of tunnel that the spinal cord runs through, and at each level in your neck, a nerve leaves the spine through this channel here. This yellow thing's a nerve, and it travels through a channel here. What often happens through wear and tear of the neck and bad posture is a bit of the disc slips out here and pinches the nerve. So what we're trying to do is widen this space. Often that disc is actually quite hardened, it almost feels like bone when you operate on it. So the idea is to try and widen that channel and free up the nerve. So this is done under a general anaesthetic. You're fast asleep, you're given a dose of intravenous antibiotics to help prevent infection, and the head is usually positioned like so. So you're lying on your front, and then the head is supported in this special frame with these 3 pins that hold it still and sturdy in place. It's carried out through a very small incision at the back of the neck in the midline, and through that incision we try and access the spine. I tend to use a microscope on this operation, so here's another view. Once we're in, just to make things more confusing, this is the back of the spine, now that's the front, and this is side to side, so this is the front here. And then the idea is we've moved the muscle out of the way to create access to this arch of bone at the back on one side of the spine. And here's the channel that we're trying to free up. So with special instruments and a drill, we try and remove this bit of bone here, and that itself widens the channel, freeing up that nerve. The one thing I want to point out, this is the spinal canal here. If you've got compression of the spinal cord, this is not the operation of choice. This is specifically for compression of a nerve and not the spinal cord. For compression of the spinal cord, the operation I prefer to use is this one, the anterior cervical discectomy infusion. There's a link below for the article on my blog page. Some surgeons use this for compression of a nerve alone and radiculopathy, which is what we're describing here. I prefer not to, because I don't like fusing up the spine unnecessarily if we don't have to. And there's a whole separate video on this operation. You can click the link here to view that. So back to the posterior cervical foraminotomy. Once we've made a wide enough channel, under the microscope I'm able to see and feel that the nerve is completely free. Then we stop any bleeding in the region and then close everything up with sutures, and I tend to use absorbable sutures to the skin. There's more information and data on the operation from the British Association of Spine Surgeons booklet on this operation. There's a link down below. The operation is there predominantly to alleviate the pain radiating down the arm, and what is quoted is about 85 to 90% of patients noticing an improvement, but it can take several weeks to notice the full benefit. The symptoms of weakness and numbness can sometimes persist, and that's more difficult to predict. The risks of the procedure are covered in the same link below from the British Association of Spine Surgeons with a lot more detail on the statistics. The serious risks that people worry about is paralysis. We're operating near the spinal cord and nerves, and that's extremely rare. Permanent paralysis from spinal cord injury, I think, is quoted as less than 1 in 1,000 or so. Occasionally a blood clot, bleeding around the spinal cord and therefore compression of the cord after an operation can cause paralysis, but that's usually reversible if you can get in quick enough and evacuate that. Other risks of the procedure include damaging that one single nerve we're trying to decompress. That can leave the arm weak. Often there's some good recovery from that, but sometimes that can be permanent. Very, very rarely is exceptionally rare. The spinal cord and the nerves are lined by a special membrane that contains this fluid that bathes the nerves. Sometimes a tear in that lining can lead to a fluid leak. Most of the time that settles down. Sometimes that needs a second operation to seal it off. Other risks include infection. Most of the time, if this is reported about anything from 1 or 2% of cases or thereabouts. Most of the time that's superficial, just under the wound, in which case some simple antibiotics can treat that. Rarely, if it's deep, you have to open up the wound and wash things out. Now remember, this procedure is not a cure for wear and tear of the spine. It's there to just decompress the nerve and alleviate pain. It can't necessarily prevent a recurrence of this. So there is a recurrence rate of the pain coming back, but I often involve our physiotherapy team, who will give you a set of exercises to do to maintain the strength of the deep flexor muscles in the neck as well as the extensor muscles. And then lifestyle changes. If you're used to sitting at a desk for long periods of time, trying to just think about your posture. There's a whole separate video of that on our blog page that can help prevent recurrences of this in the future. Then we have the sort of generic risks of surgery, one of which is blood clots in the leg, so DVT, deep venous thrombosis, and a bit of that clot from a vein can break off and embolize in the lung, pulmonary embolism, or PE. These are reported in fewer than 1 in 100 cases. You wear special stockings to help prevent that. We try and mobilize you early, which also helps prevent that. Try and stay very well hydrated. And I usually give patients a small injection in the tummy to help thin the blood a little bit the day after surgery. And then from the general anaesthetic itself and risk to life from that's extremely rare. It's reported as fewer than 1 in 250,000 cases. So these are extremely rare risks of having an anaesthetic. I hope you found the video useful. I'm going to be posting a more detailed blog article on the blog page, so please visit that. But in the meantime, as mentioned earlier, I've got the link to the British Association of Spine Surgeons website and their booklet on this operation. The mission of the spine MDT is to find the least invasive solution that also gives you the longest lasting results. Please visit our website for more information or email us, or feel free to call us on the number below and hopefully we can help you. Thank you.